Hi friends, I am Dr. Pratap Singh Rathod. I have done the MD in Forensic Medicine. In today's video, we continue with medical autopsy. In last video, we discussed about removal of organs. Now we will discuss about examination of organs. In mainly, we will concentrate about examination of chest and neck structures. Coming to proper examination of organs, examination of organs should always be done systematically from above downwards. So starting from head to neck, preferably head followed by neck, chest, abdomen, and everything should be examined, nothing should be missed. Now first, in the en masse dissection, we have seen that chest and abdominal organs are open and kept in the wooden board. They are kept usually on the wooden board with posterior surface upwards and the tongue facing the operator. This is followed by dissection of organs. Then coming to description of organs, a description of organ system should be limited to clear, concise, objective description of shape, color, consistency, and presence or absence of any lesions other than those systematically described under trauma. So any organ which we open, which has to be described in matter of their size, shape, consistency, any lesions in the abdomen is found has to be mentioned. Then coming to in which parts organs has to be described. Coming to the size, it can be measured by tape, sometimes can be interpreted by the tense capsule covering the organs, like liver. If the capsule is tensed enough, it may be because of abnormal enlargement of liver, or sometimes by blood vessels, like usually the blood vessels in heart is tortuous, but it becomes straight when if the heart is enlarged. Then coming to description of surface, most organs have a delicate, smooth, glistening, transparent capsule of serosa is present. So usually we should look for thickening, roughening, dullness, or opacity if any present on the organs. Next, shape of the organs. You should note any departure from any normal shape. If any shape is abnormally enlarged or deformed, has to be noted. Then consistency. The softness or firmness has measured by pressure by of the finger. So usually a finger is pressed on the organs, and if it is very soft or very firm, that indicates that there is some abnormality may be present in the organs. Then cohesion, it is the strength within the tissue that holds it together. So the organ which has to be held together by their properties, but sometimes in some pathological conditions it may be lost. It is just by resistance of the cut surface to tearing, pressure, or pulling. So just by using any toothed force strips, if the organ is pinched, and how much pressure is required to if the organ is friable, or if there is a reduced cohesion is present, then causes friable organ, while when it is increased, the tissue seems to be tough or leathery in appearance. So that is the can be detected by using the forceps also. Next, you have to cut the surface, cut the organ and examine. So cut surface, once it is cut, or color should be examined. Every organ, usually except brain, is basically grayish in color, or one form of grade of gray. Yellowish it may become in case of jaundice, or in fatty infiltration, or in lipofuscin, or it becomes brownish in hemosiderin deposition, or gray brown in case of malaria pigment form deposition. It may also become anemic. Anemia can cause pallor with congestion is seen, add the blue tinge to the organ. So congestion again it is seen in case of asphyxial death. So this causes mix of bluish tinge in the organs, which can be appreciated. Next, structure. This is a factor of the particular organs, like cortex and medulla of the kidney. In diseases may becomes indistinct or greatly exaggerated. So in like a kidney, there is a distinct mark of cortex and medulla is present, and obstruction or any distinction mark, if it is not present, that indicates some abnormality is present. So cut surface has to be described based on the change in the color or change in the structure of the parts of the organ. Next, coming to organ specific dissection. Coming to organ oral cavity examination. So examination proper of some part of the body. So we'll start with oral cavity, then we'll go for neck, then lungs and heart. So in oral cavity we examine for tongue. It is examined for any diseases or any injuries. Usually in case of violent asphyxial deaths like in smothering or throttling, sometimes the tongue is injured, or sometimes there may be bite marks may be present. So if the person is violently dead, in cases the bite marks may be present. Severe incisions can be made through the tongue to examine the bruises. So usually tongue incisions can be taken along the length and to examine if there is any contusions or bruises are present. The pharynx, epiglottis and glottis should be examined, especially for foreign objects present. So it may be present in cases of choking. Death by choking, foreign objects may be usually present in the epiglottis. The condition of the tonsils should be also be noted. Then next structures is examined. A large blunt pointed scissors is used to cut open the esophagus from the posterior surface from the cardiac end of the stomach. Then lower end of shows posterior postmortem erosions due to the regurgitation of gastric juice through the relaxed cardiac sphincter. So usually a blunt scissor is used to open the esophagus from the posterior surface, and it is continued till to examine the inner surface of the esophagus. So note if any presence of any capsules, tablets or powders is noted, and it should be preserved. So these cases of like poisoning death, so in esophagus, sometimes near the esophagus also some capsules or tablets may be present. Special precautions should be taken in case of varices, since if it is not noted, then dissection may lose, cutting of the varices it may be lost. Injection of saline or colored fluid into the varices is useful to find any leak from the tears. So if the person has died because of tear of the varices, so usually injection of saline into the enlarged veins can make the tear to appear. Then examination of larynx. Larynx lies opposite to third to sixth cervical vertebra. Usually it may vary depending on the person. The larynx, trachea and bronchi are examined by cutting them open from posterior surface. So usually the posterior surface is cut to open and examine if any presence abnormality is present or bleeding is present or any foreign object is present. Then presence of blood, mucus, foreign bodies, vomiting matter, tumor, inflammation, mucus, if any present, should be noted. Then thyroid is removed, sectioned and examined for any abnormalities. Then parathyroids are examined. Carotid arteries must be examined for the presence of thrombosis, particularly bifurcation near the skull, which may be present. Then hyoid bone, thyroid, cricothyroid cartilage are examined for any fractures and contusions. Followed by next is the jaws is examined. For to examine the open the jaw before, if tongue is not dissected, usually jaw is opened. If trigger is set, then jaw is usually opened by dissecting the masseter and temporalis muscles, which are divided above their insertion into the mandible, to allow the jaw to become mobile and examine the jaws internally. So this is mainly useful in cases if the violent asphyxia like smothering, in that cases can be helpful. The maxilla, palate and inferior part of the facial skeleton is removed by sawing horizontally across the maxilla at the level of lower margin of nasal aperture, taking care of the upper tooth roots. Again, this dissection is usually not done routinely, so it can be sometimes it may be done if pathological condition is recommended. Then coming to lung dissection. So after next structures, esophagus, larynx, thyroid, everything is examined. Next you examine for the lungs. So lungs examination, lungs are placed in the anterior surface, uppermost pulmonary arteries is opened and continue to the lung tissues as far as small incisors will allow it to go. So usually the first is the pulmonary arteries as dissected. They are cut near the hilums and heart is separated, vessels are separated. Then pulmonary arteries at the hilum are examined for any thrombi, emboli, arteriosclerosis. Next, pulmonary veins is examined into the lungs for evidence of thrombosis or embolus. So pulmonary veins also which are entering the lungs has to be examined, followed by lungs which are separated at the hilum. So pulmonary artery and pulmonary veins are first dissected to near the hilum for presence of thrombus or emboli. Later on, Lung is separated on both near the hilum by using long blade knife cutting along the hilum. Then lung is held on the upper surface by the left hand and the organ is cut across from apex to base with large brain knife held parallel to the board. So after the lungs are separated, so each lung is dissected taking longitudinal incisions along the long axis from apex to base. So this is how the organ is dissected, and each after each incision any abnormalities or any loss in patency, loss in the obstruction in the pulmonary arteries, pulmonary veins, trachea are examined. So dissection is done on the lungs from apex to base and every part is examined. The lungs is examined for consolidation, edema, emphysema, atelectasis, congestion, tardus pars, embolus, tumor, infarction, etc. So every part of the lung is examined for any abnormalities. Small bronchioles are examined for mucosal thickening, infections or blockages. Small pulmonary arteries are examined for thrombosis or embolism. Next, aorta is examined. Aorta again near the heart is examined. So aorta, arch of aorta, ascending aorta, horizontal aorta and descending aorta has to be completely examined. The scissor is passed into the iliac vessels and the whole length of aorta is cut on its posterior surface. So from descending aorta, the incision is taken from till throughout the heart till aortic valve for examination. Any plaque formation, obstruction at the mouth of the coronary arteries is examined. So near the base of the aorta, usually coronary arteries are present, and usually if there are any obstruction are present has to be examined. After that, heart is dissected out. Heart is removed with great vessels attached and at least 1 centimeter beyond the pericardial fold. So usually with heart along with the great vessels has to be dissected out. In situ examination of pericardium is done for adhesions, pericarditis, discoloration of any underlying infarct, aneurysms, injuries and any fluid or blood. So before removing the heart, pericardium is examined for any abnormalities. Pericardium is opened with inverted T-shaped incision is taken and pericardium is separated if no abnormality is detected. After pericardium is separated, heart is pulled out. Heart is measured from base to aorta. So usually heart is present and it is measured from apex vertically. The size to measure the size of the aorta from apex to base is first measured, and for width is measured between the walls of circumference between the AVO circles. So width is measured at the level of the walls and the circumference measured at the anterior atrioventricular junction. So that's the how the heart is measured. The surface is looked for any visible fibrosis or recent infarction. The pulmonary arteries should be palpated before they cut for presence of thrombus or embolus. The pulmonary arteries which enter the atriums has to be examined for presence of any thrombus or embolus. If thrombus is felt, right ventricle and pulmonary trunks are open in situ and size and extent of thrombus is noted. Superior infravena cava should be examined for presence of thrombus or embolus. So superior infravena which enter the right atrium has to be examined for any presence of embolus. Thrombus are usually in pink in color and firmly adherent to the vessels. Postmortem clots are soft, fibrous, yellow or red in color. So antemortem thrombus are pink in color. Postmortem thrombus are usually friable, easily lost in consistency and yellow and red in color. The heart is held at the apex and lifted upwards. So holding the apex, it is lifted upwards, and pulmonary vessels, the pulmonary vessels which are present, superior infravena cava which present has to be, and ascending aorta are cut as far as possible from the base of the heart. So the aorta superior infravena cava has to be dissected till and cut open. Heart is isolated for the examination. Then heart is dissected by using inflow outflow method commonly used by using the instrument entrotome. This is the entrotome which has a one blunt end which is used to place inside the valves for cutting. So heart is opened in the action of the flow of the blood inflow outflow method with entrotome. So first the right atrium is cut between the openings of superior and inferior vena cava. So first decision is taken between the superior and inferior vena cava. So from superior and inferior vena cava, the heart blood flows into the right atrium. So that is first the dissection. After that, the flap is opened and right atrium is examined. Then second incision is small secondary incision is made to open the right auricular appendage to detect the embolus. So once the between the superior and inferior vena cava, then the atrium is right atrium is separated and examined for thrombi. Next incision is taken from base from the ventricle. From the endotrauma is introduced in the right atrium, cut through the tricuspid orifice and opens the right ventricle along the lateral margin. So from the right atrium, the incision is taken along the margin tricuspid orifice and opens the right ventricles. So this is the second incision, followed from the in the anterior surface the first incision. Then circumference of the valve is measured using the graduated cones. So to measure the tricuspid orifice, we can use the cones which has gradations are present, which can be inserted in the valve to measure the circumference to look for the patency of the valves. So after the from right atrium to right ventricle incision is taken. So from right ventricle it will goes to the pulmonary arteries. The competency of pulmonary valves can be observed by flowing a gentle stream of water towards the valve. Cups comes into composition whether water leaks into the artery. Already open ventricle is seen. So if we want to know whether the valves are functional, water can be inserted into the pulmonary valves which are usually present, and if water doesn't flow, it indicates that pulmonary valves are intact. Then the next incision with apex is directed towards dissector. Endotomy is introduced into the right ventricle. So from right ventricle, from here close to the apex and the conus pulmonaris and pulmonary valve are cut about 10 mm to the right of and parallel to the interventricular septum. So from after the right atrium to right ventricle, next from right ventricle, so the second incision goes from here to pulmonary artery. It from the apex towards the pulmonary artery from about 10 mm from the interventricular septum. So this is from the interventricular septum. This is the interventricular septum. About 10 mm from the interventricular septum, the incision is taken, which is identified by anterior descending branch of the coronary vessels. So this is the descending branch of coronary vessels. So about 10 mm from that, second incision is taken. The third incision is taken. Next, the incision should extend into pulmonary trunks and the left pulmonary arteries. The contents of the right ventricle and auricle may be fluid, blood, current jelly, or chicken fat clot may be present. From after the third incision, left atrium is cut between the openings of the pulmonary veins. So pulmonary veins are cut. So this is the pulmonary veins. So pulmonary veins are cut along their presence, and left atrium is cut along its lateral wall. So cutting the pulmonary veins, we expose the left atrium, which is present here. So left atrium is exposed and we can examine for thrombus. The incision extends through the mitral wall first and passes along the lateral margin of the left ventricle up to the apex. Then circumference of mitral wall should be also be measured. So the last incision is extends again from the left atrium to left ventricle, and from left ventricle to left ventricle, and left ventricle to the last incision will from the aorta. Next incision extends from the apex along the interventricular septum into the aorta, opening the aortic wall. So the water competency of the aortic wall can be tested from cutting the aorta transversely. Both auricular appendages should be examined for presence of thrombi. So this is how the method is done. So to summarize, from superior vena cava, and inferior vena cava, first incision is taken. From both right atrium, the right atrium enters to right atrium. From right atrium to right ventricle. From right ventricle through the interventricular septum, it goes to the pulmonary arteries. So here, so from pulmonary arteries to pulmonary veins, from pulmonary veins to left atrium, from left atrium to left ventricle. So from left, this is the left atrium. So from left atrium to left ventricle, the incision is taken. So from left ventricle to aorta. So that completes the heart dissection. So this is the inflow to outflow method. The intra-atrial septum is examined for patency for foramen is also noted. Chordae tendineae, papillary muscles examined for infarctions, adherence to each other, rupture of any chambers or any fibrosis present or infection present has to be examined. The heart is weighed and thickness of the right and right ventricle should be taken. The muscles of the right and right ventricle is incised in a plane parallel to epicardial and epicardial surfaces, which reveals the infarction and fibrosis most clearly can be seen. So, even along the muscles of the intervertebral septum, right ventricle, incisions can be taken to examine for presence of infarction and fibrosis. Now, coming to next is coronary artery dissection. As anatomy or coronary varies, there is usually a main trunk of left coronary artery which soon bifurcates into circumflex branch and anterior-descending branch. So this is the circumflex branch which circles the arch and descending branch. So, osteotomy of the coronary arteries should be examined for patency, lumen, thrombosis, or any narrowing. The coronary arteries are examined before opening the heart by making serial cross sections along the entire course of the major vessels about 2 to 3 mm apart using a scalpel. So, usually to examine the coronary arteries, the main arteries are cut before completely dissecting the heart. Coronary arteries examined by taking 2 to 3 cm apart small incisions along the main trunks to detect any presence of any loss of competency, loss of patency, presence of thrombi. So, these serial incisions has to be continued to know if and examined for presence of any thrombi. The most common site of thrombosis is 1 cm away from the origin of the left coronary artery. The presence of acute coronary lesions, example plaque rupture, plaque hemorrhage or thrombus should be noted. Some abnormalities present can be in the heart is include subendocardial hemorrhages. These hemorrhages are seen in the left ventricle, which are flame-shaped confluent and tend to occur in one continuous sheet rather than the patches. It can be seen in severe hypertension, intracranial hemorrhages, ectopic pregnancies, ruptured uteruses, antematernal postmortem hemorrhages, and abortion and cases of poisoning. Mainly in case of arsenic poisoning, it is seen. Antematernal thrombi in the heart. They are dark red, firm but friable, dry, pale, granular, adherent to vessel walls, and on section shows alternate layers of platelets and fibrin. The postmortem thrombus are usually dark red, glistening, soft, jelly-like, and very friable. So easily it can be pinched. Agonal thrombi. These are seen in case of person dying agonally. In person dying slowly with circulatory failure, a firm, stingy, tough, pale yellow thrombus forms in the cavities, usually on the right side of the heart. Postmortem clots, there are usually two types. One is current jelly and chicken fat. So in current jelly, the blood clots rapidly forms soft, lumpy, uniformly dark red, slippery, moist, which is called as current jelly, red current jelly clot. When red cells sediment before the blood coagulation, the red cells produces a clot similar to that of first type, but above this there is a pale yellowish layer of serum is deposited, which is termed as chicken fat clot. Both are postmortem clot which is formed after death. Then postmortem fluidity of blood. In most deaths due to asphyxia, blood becomes fluidic and incoagulable. It is due to fibrinolysis, which is liberated from the vascular endotheliums. Fibrinolysis activation occurs due to release of plasminogen activated through the receptors in the vascular walls for various vasoactive materials that increase during the agonal period. So, if any person who dies because of agonal conditions, sometimes fibrinolysis releases and causes the fluidity of blood. Then unclotted blood. So, in certain deaths, clots are greatly reduced in amount. The blood remains fluid in certain cases of septicemia and carbon monoxide poisoning, rapid deaths from asphyxia, large doses of anticoagulants in hyperfluoridemia and amniotic fluid embolisms, retained abortions, and peripheral sepsis. These are my references. In next video, we will discuss about abdominal organs dissection. Thank you.